Okay. With regards to Rh negative mothers, I'll start with how the case is supposed to be handled. Basically, with regards to the long case presentation, as per Prabodhana sir's obstacle, we start off with an introductory statement, then go on to the if there are any previous pregnancies, the outcome of the previous pregnancies, like whether there was any severe fetal anemia, high drops, or intrauterine death, or whatever. Then after that, the preconceptional period for this pregnancy, the pregnancy diagnosis, and then after that, any specific events that happened in T1, T2, T3. I mean, we have to talk about the general things that we say during any pregnancy related presentation in T1, T2, T3, but like specific for Rh negative, we need to talk about the sensitizing events occurring in T1, T2, T3. I'll get to that later. And also the other specific screening that is done over the course of pregnancy. So, with regards to the booking, now, like I've already mentioned what has to be said about the previous pregnancy outcomes. In the introductory statement, we have to say whether she's in her first pregnancy or second pregnancy or whatever. And if she's in a second pregnancy, after mentioning her blood group, if, for example, if it's O negative or something, we need to say if if she's sensitized or not sensitized. If she's sensitized, we might have to mention the antibody titer as well, as per what Prabodhana sir had said before. And with regards to the booking visit, we need to talk about the mother's blood group and DT, the father's blood group also, and whether she was screened for unexpected antibodies. Now, the screening for unexpected antibodies, I'll get like the algorithm after that, I'll get to that under the management, right? Then the specific events in T1, T2, T3, we need to talk about the sensitizing events. So the sensitizing events are mainly, it's then Chandana sir's lecture. So the sensitizing events he specifically mentioned were um, like the main thing is birth of the baby. Then other things are therapeutic or spontaneous abortions, ectopic pregnancy, threatened miscarriage. Then other clinical procedures like chorionic villus sampling, amniocentesis, chodocentesis, and external cephalic version. So whenever these since these instances where alloimmunization can occur, whether the mother was covered with an additional dose of rogam should also be mentioned in the history, right? And also, anomaly scan is very important in the 20-week mark. And then I'll get to the other important points that have to be mentioned, like when I discuss about the management. Then, with regards to the management per se, so at the booking visit, we have to talk about whether or not the unexpected antibody screening was done. Now, if she was negative, now if she was an Rh negative blood group and she was negative for unexpected antibodies, again, the unexpected antibody screen has to be repeated in 28 weeks and 32 weeks. Now, let's say she was positive, then we have to repeat this every 4 weekly until 28 weeks, and from 28 weeks, it has to be repeated until 2 weekly. Now, during these scanning, during these screening procedures, if the critical antibody titer is reached, the critical antibody titer is 1:32. So, if the critical antibody titer is reached, additional investigations have to be done. So particularly what they go for is this middle cerebral artery peak systolic velocity, right? And that there is like a famous question is that the sensitivity of that test is 100%. So MCA PCV is done. If the MCA PSV is more than 1.5 times the multiple of median, there is a high chance of fetal anemia. And then if it's more than 1.5 times the multiples of median, we might have to deliver or we might have to do intrauterine transfusion. If it's less than 1.5, we repeat it every 2 weekly until it hits 1.5. So and this middle cerebral artery, the peak systolic velocities, it's reliable between the gestational period of 18 weeks to 34 weeks. So after 34 weeks, the peak systolic velocity of MCA is not reliable. Then if so, like, then another question they can ask is, how do you, like, what are the features of severe fetal anemia? So that also know, if severe fetal anemia, generally they develop this high output heart failure. So if we remember it like that, one thing is they have hyperdynamic fetal circulation. That's what we are detecting with the middle cerebral artery peak systolic velocity. Additionally, they can have like an enlarged fetal heart, polyhydramnios, reduced fetal movements, and abnormal CTG. So in abnormal CTG, initially they will present with reduced variability, and eventually, if a marker of severe anemia is a sinusoidal trace. And they can ask about the in addition to this middle cerebral artery peak systolic velocity. Earlier they used to do this thing called amniotic fluid spectrometry, but currently they don't do it because this MCA-PSV has 100% sensitivity and it's very easy to do. Then they can ask other questions they can ask in the long cases about this percutaneous umbilical cord blood sampling. And this PUBS is done to detect fetal red cell indices. It can be done from 18 weeks onwards, right? So, and it's generally done from the placental cord insertion or the intrahepatic umbilical vein. So the problem is there is a high risk of fetal loss. So unless, so we don't do the procedure has a high risk of fetal loss, so we don't do this percutaneous umbilical sampling unless we detect severe fetal anemia using the peak systolic velocity MCV. So, like, the thing is now when this PUBS is done, we should be prepared at the same time to go ahead with intrauterine transfusion if necessary, right? So, intrauterine transfusion is done also like only after 18 weeks. Now, if the fetus is less than 18 weeks, like very premature, we can't go for intrauterine transfusion. We have to go for something called intraperitoneal transfusion. So when we do intrauterine transfusion, a common question that they can ask is the type of blood that is used for transfusion. So for that, you go for O negative, CMV negative, washed irradiated packed cells, which are cross-matched against maternal blood. That's also there in Chandana's lecture slide. And another thing that is usually done at DMH is if the gestational age is more than 34 weeks, they deliver and they don't go for multiple intrauterine transfusions. Uh, they can also ask about um, they can ask about they can ask about Rogam. The one that is available in DMH is Ro clone, which is a human product, and the half life is around 3 months. It's an intramuscular injection, and it's the dose is 300 the dose is 300 micrograms. And yeah, for SCQs, they can ask about the pathophysiology of hemolytic disease of the newborn, and for that there are that's also there in Chandana's lecture slide. There are three main points that have to be addressed. That is, a paternally derived red cell antigen that is foreign to the mother should be inherited by the fetus, and secondly, the volume of the fetal red cells that gain access to the maternal circulation must be sufficient enough to stimulate an immune response. That is, those are the sensitizing events. And finally, maternal antibodies to the fetal red cells must gain transplacental access and cause immune destruction of the sensitized red cells. So technically, this can't happen in the first pregnancy because in the first pregnancy, you get the primary immune response. Primary immune response is small in magnitude, and IgM antibodies, which are pentameric antibodies, are generated. And these IgM antibodies, they cannot cross the placenta. So generally, the secondary, like in subsequent pregnancies, you get an IgG-mediated secondary immune response, which is large in magnitude. And these IgG antibodies can easily cross the placenta and cause immune-mediated destruction of the fetal red cells. And another MCQ point is that if the mother is sensitized once, she will be sensitized for life. Yeah, that's all. Hello? Hello? Yeah, Tika, that's all. Yeah. Okay, bye-bye.